Welcome to everybody. My name's Paul Haber, and this is a Sydney Addiction Seminar, and the third one that we're having, and the last one that we're having for 2020. And I'm delighted to welcome a really expert panel to give what I'm sure will be an interesting presentation around e-cigarettes, vaping as you call it. Some of us might have our attention to the Northern Hemisphere for the American elections, but as we were saying, it's after 2 a.m. over there. Nothing's going to happen. You may as well sit back and enjoy this particular show and clock into that later on. Let me also acknowledge the Aboriginal owners of the lands that we're on. I'm in the Gadigal area, but I know people from all over the state, from all sorts of places, and welcome, pay my respects to Aboriginal elders past, present and emerging, and to any Aboriginal people who have dialed into this meeting. Now, in terms of using Zoom, can I just please ask for everybody who's not actually talking, our presenters included, to go on to Zoom, to go on to mute when you're not actually speaking. And if you could please turn your videos off as well, because it really reduces the bandwidth required and makes it more likely that we'll get through our presentation and hear all of our speakers. You can also please feel free to use the chat function to record your questions, and I'll moderate the question and answer by selecting from the chat. It's much better with larger audiences if we rely on chat for our discussions as much as possible. So we have 4 presenters today: Colin Mendelsohn, Carolyn Beaumont, Adrian Dunlop and Billie Bonevski. The first presenter is Colin Mendelsohn. Colin is a GP by background, but has a long-standing track record and interest in helping people to stop smoking, basically, but has been really become expert in and a powerhouse in understanding the vaping e-cigarette modality. And he now works exclusively in tobacco treatment. So Colin is going to set the scene, give us the background and explain to us what's going on. And then our other speakers are going to give us, firstly, a practical approach to how they treat patients, and then to talk about some of the research, the cutting areas and where this field is headed. So let's start by handing over to Colin, and I will turn myself on mute too.
Paul, thank you very much. Thank you for asking me to talk about my favourite subject. We don't call them e-cigarettes for obvious reasons anymore. We tend to call them vaping products or vaporizers. E-cigarettes carries the word cigarettes, which has a lot of negative baggage, so vaping products in general we'd rather use. Let me share my screen and bring up my presentation, which is here. Share, and then... Okay, we'll go back, hang on, go back to the beginning. Okay, so just by way of disclosure, I've never received payments from e-cigarettes or cigarette or tobacco companies, but I am the director of the Australian Tobacco Harm Reduction Association, which is a health promotion charity, and we have taken unconditional donations from the vape industry early on to set up the charity, but we don't anymore. We haven't for nearly 2 years, or a year and a half. So what I'm going to talk about today is what's the situation in Australia in regard to vaping in terms of numbers and demographics. I want to look at safety, effectiveness, updates on what the colleges are saying, and the legal situation. So first of all, just as a broad overview, you would all be aware that vaping is basically a form of tobacco harm reduction. So what that of course means is it's a less harmful substitute for adult smokers who are unable to quit smoking or are unwilling to give up smoking or nicotine. And it's all about reducing harm, not eliminating harm. It's not about eliminating nicotine, but about reducing harm, about preventing people who are going to continue to smoke anyway from smoking-related death and disease. And the reason it works so well is it gives people who are addicted to nicotine the nicotine they crave, but it also replicates the smoking experience. So they get the hand-to-mouth ritual, the sensory aspects of smoking, um, the social aspects of smoking. They can vape with other people, vape with smokers. But what it doesn't deliver is the 7,000 chemicals or very, very tiny amounts of the chemicals that are in tobacco smoke, which are responsible for most of the harm to health. So it's giving them what they need, but without the poisons. And it's no different to other established public health harm reduction strategies, which are well accepted and effective, like methadone for heroin users and clean needle exchange, all those things that we've been using for a long time, we know work well. To put a human face on this, I'm going to start with a video of Rachel. So let me introduce Rachel and we'll talk a little bit more about her later.
My name's Rachel, I'm 37 years old, I'm proudly Indigenous, and I used to work as a registered nurse in oncology prior to having to retire early. I live a very socially isolated life. I live on my own with my dog. I'm dependent upon disability support pension, and I have daily assistance with support workers from the NDIS. I primarily suffer from rheumatoid arthritis, but I also have suffered multiple episodes of pulmonary embolisms, most likely, if not caused by smoking, very heavily related to it. I also have suffered with endometriosis and required bowel surgery as a result of that. Several years ago, I contracted shingles on my cornea, and that caused near blindness overnight. I also have huge battles with depression, anxiety and panic disorder. Depression is a big part of my daily life. I was about 16, 17 when I started nursing, and it became very evident to me very early on that smoking was disastrous to health. And I also had a lot of pressure from family as well. I think as a lot of young people think that they're bulletproof, nothing's going to happen to them, that smoking isn't going to catch up with them. But the longer that I nursed, the more evident that it became to me that it will catch up with you, and it was going to catch up with me, and I needed to do something about it. I battled tobacco addiction for the best part of 15 years of my life. I smoked probably 30 to 40 cigarettes a day, and it cost me a lot. It would cost me hundreds of dollars a week. A couple of $100 a week was not uncommon. I've had multiple quit attempts. I tried Champix, I tried nicotine patches, I tried lozenges, I tried gum, I tried sprays, I tried hypnosis, I tried acupuncture, and I tried cold turkey. Mainstream quit smoking aids cost me as much as what smoking did, and didn't work. Nicotine patches caused severe skin irritation to the point where my skin came off with the patch. Lozenges, gum and spray caused severe gastric distress. Champix put me in hospital suicidal.
So, yeah, Rachel is a vapor who lives in Newcastle, up near you, Billie. And I mean, she's a typical sort of patient that we tend to see these days, a disadvantaged patient who's suffering from a range of smoking-related illnesses, is in financial pain as a result of smoking, has tried repeatedly to quit, and really the only choice for her is to keep smoking because the conventional treatments just aren't working. So we'll come back to Rachel a little bit later. Let's move on to the other vapers in Australia, there are now over 500,000 people currently vaping in Australia, and that's defined as at least once in the last 12 months. About 200,000 of those are ex-smokers. Most of the rest are dual users, so they're still in that transition phase of smoking and vaping, but many of those will go on to quit. The important thing is that vaping is rare in never smokers in Australia. And these are figures based on the recent National Drug Strategy Household Survey, but 0.7% of the never smoking population currently vape. But most of those vape once or twice, very occasionally, and only transiently. And 93% of never smokers, in fact, are no longer currently, vapers are no longer currently vaping amongst never smokers. And regular use amongst never smokers, which is what's really important for public health, is actually very rare. So less than 3 in 1,000 people who've never smoked currently vape. In Australia, vaping is the most popular quitting aid, and as it is in most Western countries, and people are using it for the sort of reasons that we would like to see. So typically to quit, to cut down, to prevent relapse, and to avoid the harm from smoking. Vaping is most concentrated in the lower age groups, in the 20s, late teens and 20s, and it flattens out after about the age of 30. Vaping by youth in Australia is, I think we'd have to say, quite rare in terms of the non-smokers in particular. So you can see from this graph that about 8% of non-smoking youth have tried vaping, but only 1.3% of non-smoking youth are current vapers. We don't know the frequency from this study, but from other studies in Australia and the US and the UK, we know that regular use amongst non-smoking youth is less than 0.5%. So yes, young kids are vaping, and it's better they don't, but actual regular use, which again is the metric of public health importance, is actually quite rare. And just a reminder, this is all about relative risk. So yes, there are harms from smoking and vaping, but from vaping, it's not risk-free, but it's far less harmful than smoking. And you can see the risk from combustible products down this end of the scale, and the non-combustible alternatives, such as e-cigarettes, vaping, are very low. And how low? Well, the figure of 95% less harmful was established by the Public Health England and the Royal College of Physicians several years ago. The more recent evidence gives us no reason to believe that's changed. And it's logical, as you'd expect, if most of the toxic chemicals in smoke are absent from vapor and people aren't being exposed to those. Those that are present are generally less than 1% of what they are in smoke. And our confidence about safety is increased by findings of biomarkers. So these are the toxins in the blood or urine or saliva of vapors, are substantially less than they are in smokers. In many cases, are the same as in non-smokers. We see significant clinical improvements in many smokers in conditions such as asthma, COPD, high blood pressure. And the evidence is showing no material risk to bystanders in terms of secondhand vapor. Just wanted to make a quick word about EVALI, which was the lung injury that was occurred in North America end of last year, beginning of this year. This was an outbreak of serious injury to the lungs in people who vaped, but we now know that all of those cases, almost all, if not all, were due to contaminated THC or cannabis oils, contaminated with vitamin E acetate. And there's not been a single case linked to commercial vaping products of nicotine. So that's a really important distinction. The evidence on effectiveness is growing. We know that vaping is more effective than NRT. In randomized controlled trials, that is certainly the case. We've had 3 recent meta-analyses, including one Cochrane review, which came out a couple of weeks ago, all of which have come to the same conclusion using the three most reliable trials with the least bias and well conducted. And there was moderate certainty of evidence based on the number of trials. So we need more trials, but consistently we're seeing that vaping in randomized controlled trials is effective. And that's confirmed in all the other evidence that we're seeing. So when we're assessing the effectiveness of vaping, what we need to do is triangulate all the different types of evidence because all the different types of studies have different benefits and disadvantages. But when you bring them together and triangulate that data, which includes observational studies, population studies in large populations in the UK and the US, the decline in national smoking rates where vaping is available, and the fact that there are 68 million vapers now in the world who are clearly benefiting from vaping. When you put all that together, the studies in a controlled environment, the real world studies, we have growing confidence that vaping is an effective quitting aid. One piece of evidence which supports that is the decline in smoking rates in countries where vaping is available. So all these countries, the USA, England, and Australia, have done everything that they can to bring down smoking rates. The only difference is in the US and the UK, they have widespread vaping. In Australia, we don't. And our smoking, the rate of decline is a third of what it is in those two countries. And that's based on adult smoking over the last 6 years using national data, official national data. So the decline in smoking in Australia has not plateaued, but it's slowed significantly compared to those other countries. And vaping, we can't say for sure is the cause of all of that, but we know it's a significant factor. The medical colleges are coming on side slowly. They're all rather conservative. The College of Psychiatrists was first back in 2018, and they very strongly support vaping, obviously because people with mental illness have high smoking rates. They can treat their mental illness, but these people go on to die of smoking-related disease. So the college is very aware of that and very concerned about it. Similarly, the Royal Australian College of General Practitioners now supports vaping in a cautious way, but their position is that if the patient's unable to quit and they've tried conventional methods and they ask the health professional about vaping, it's reasonable to use vaping. So it's a second line treatment, and that's how it's promoted. The College of Physicians has most recently come on board in acknowledging a place for vaping. So again, they see it as a second line treatment. They acknowledge that the evidence is growing, and it's moved on from when they made their position paper a couple of years ago, and just recently the position has been taken that they would encourage it for people where it's appropriate. One of the small problems with vaping in Australia is that nicotine is classified as a dangerous Schedule 7 poison in the poison standard, and it is a criminal offence to sell, possess or use nicotine for vaping. And there are serious financial penalties and potential jail sentences for people who do that. But the one good thing is that it is legal to import and use 3 months supply of nicotine at a time, as long as you have a prescription from a registered doctor. And that's allowed under the TGA personal importation scheme. So if people have a prescription, it is completely legal. And Carolyn's going to talk to us more about that later, about how to actually write a prescription. So let's just come back to Rachel and see how she's done since she got to the end of that journey of being totally unable to quit. Let's see what's happened since.
15 months ago, I had a family member that suggested vaping to me. He'd been successful with quitting smoking using vaping and knew the struggles that I'd gone through with other quit methods and thought that it would probably be a benefit. He took me to a local vape shop and I bought my first device, and within days I was vaping, and that was 15 months ago. I haven't picked up a cigarette since, and I have no intention to, provided I still can have access to liquid nicotine to continue treatment for my tobacco addiction. Although medically retired from registered nursing, I've read widely into vaping and thoroughly into vaping, and I wouldn't vape if I wasn't satisfied with the risk that I was taking. It is much better for me than what I was facing with continuing to smoke deadly combustible tobacco. Since I started vaping, my rheumatoid arthritis has improved out of sight. I haven't had any pulmonary emboli, not a single one. I'm sleeping better, I'm breathing better, and my depression and anxiety has improved drastically. I'm a member of a wonderful online community that supports me, and we support each other in giving up tobacco. The proposed new legislation will have quite a severe impact on me. I'm feeling really fearful, anxious and afraid, to be perfectly honest. Things are difficult for me as it is, and having to get a script so that I can continue my treatment is going to be very difficult for me. As a result of this legislation, I can only see possibly two options that I have. One of which is going back to smoking, which I desperately don't want to do. I've had so many amazing benefits from stopping smoking and starting vaping, and all of that's going to be put at risk. The other option is to go to the black market, and I really don't want to do that. I don't want a criminal record just because I've chosen to use vaping as a method to quit smoking. I'm appealing to the government with every fibre of my being. Please don't force this ill-thought-out legislation that won't work upon me and my fellow Aussie vapor family.
So I'll just stop sharing there. And yeah, the new legislation that Rachel's concerned about is that the health department wants to make, they want to confirm the medical model for vaping, which is to make doctors, make vapers get a nicotine prescription if they can find a doctor who'll give it to them, and then purchase it from pharmacies if they can find a pharmacy that will dispense it. And they're trying to also ban imports of nicotine through the personal importation scheme. So that's what vapers are worried about. And this video was partly produced as an advocacy video to promote that, to counter those government proposed regulations. So that's the end of my presentation. I'm happy to take any questions now if there are any.
Just a reminder to anyone, you are welcome to unmute yourself, or you can also use the chat function. Either are acceptable.
Thanks. I'm sorry, I should have unmuted myself first because I was talking away quite nicely there. So the challenge is, I think we've got a collection of speakers tonight who are very interested in vaping, and if I could be so bold as to summarise them as being pro-vaping. Yet there's a very large, perhaps more conservative, but nonetheless a very large group of our health profession and government who actually see it as incredibly harmful and dangerous and risky. So some of the challenges, some of the problems that have been raised include things like lack of evidence, problems of youth taking it up, the fact that it's a gateway to smoking or potentially a gateway to renormalising smoking, and the fact that whilst we think the risks are low, some of the references to there being such low risks, such as the UK report that you cite, is not actually direct evidence, but a report from an agency that's actually quite a few years old now. So I wondered if you might sort of rebut me and tell me why all of those concerns are not anything that we should be worried about.
Yeah, look, no direct evidence. Of course, we have no direct evidence. We need to wait 30 years to have direct evidence. But if you look at basic scientific principles, the fact that vapor has a huge reduction in the toxic chemicals that cause disease, it's just common sense. We may find out that there are problems that arise over time, but with any new drug, we make a decision based on the evidence we have. We have over 6,000 peer-reviewed papers now on vaping. We have 68 million vapers. There hasn't been one death from vaping in that time. Serious reactions are extremely rare.
I think there's been at least one child in Australia has died. Actually.
Yes, that's not the reaction to vaping, but that's the concern. And the reason for that death is that we ban vaping in Australia. So people import very highly concentrated nicotine solutions in non-child-proof bottles. If we regulate vaping, which we've been campaigning to have done, people will buy low concentrations of nicotine from their local vape shop in a child-proof bottle, and we won't see those problems. There have been 4 deaths in children in the world in the last 15 years. So it's really important to keep that in perspective. It's a tragedy, of course, but 8 million people die every year from smoking. Just in terms of youth vaping, Paul, what's really important is that, yes, we hear these headline figures of youth, young people who have vaped at some point, lifetime vapers. But what's important is that most of that vaping is experimental and it's transient. And regular vaping by never users is actually very rare. So it's less than 0.5%, and people who've never smoked, less than 0.5% of kids who've never smoked are actually regular vapers, meaning more than 3 times, 10 times, or 20 times a month, depending on the country. So, and the idea of a gateway has not been proven. You know, you remember the reefer madness concerns about marijuana and all the arguments about gateway. What's much more plausible is that young kids who try vaping are risk takers, and they're more likely to go on to smoke, to use cannabis, to use drugs, have unprotected sex, drink alcohol to excess, and there is a strong association with all those things. So we think the kids who take up vaping and then smoke would have been more likely to smoke anyway. And in fact, what we're finding in overseas studies is that smoking rates in countries where vaping is available amongst youth are declining faster than ever. So last year in the US, the youth smoking rate fell by 25%. Even though kids were trying vaping, they are smoking less. And we think that vaping is actually diverting a lot of kids from smoking. So kids who might have smoked will try vaping and not go on to smoking.
Thanks, Colin. Of course, you've convinced me absolutely, and thank you for those answers. There have been a few questions on the chat, but some of them, just if I can tell the questioner, will be answered as we proceed through the program. One question has asked, is this product registered by the TGA?
Well, that's a very good question. We don't believe that these products are medical devices, and they really shouldn't be under the jurisdiction of the TGA. So in every Western country, these products are consumer products. So they're replacing an existing consumer product. They're a substitute for cigarettes. Cigarettes aren't registered by the TGA, and we believe it's quite inappropriate that they don't make medicinal claims. They're not therapeutic products. We don't believe they should be assessed by medical standards of a medical quality like other medicines.
So if it's not a therapeutic product, why do you need a prescription for it?
Because currently the government says it is a therapeutic product, but it isn't anywhere in the world, and there hasn't been one product registered by any medicines regulator anywhere in the world that's gone to market. So the idea of medical registration is just inappropriate.
Well, I think that's one view, and I think I will leave the audience to ponder that very interesting question and your interesting answer, and move on to the next symphonic presentation. Or have I got it wrong? Is it not the symphony trial, but the harmony trial? The next presenter is going to be Billie Bonevski, and I think with Adrian Dunlop as well. So this is kind of a new, about the Ballad of Newcastle. So Billie Bonevski is an NHMRC Career Development Fellow, a behavioural scientist and a professor at the University of Newcastle, whose smoking cessation programs are being implemented by cancer councils across the nation. She's really an expert in all things non-smoking and is a key investigator on this Harmony trial. And I really look forward to hearing about the Harmony trial, because I'm going to be part of it. So it'll be really exciting for me to understand what I'm up to. So over to you, Billie.
Thanks, Paul. Can you hear me okay? And my screen is shared, right?
Yes.
Okay, great. Yeah, so look, Adrian Dunlop and I are doing a double act describing the Harmony trial. I'm going to provide a little bit of a background and rationale, explaining why we went ahead with designing this this study, which is funded by New South Wales Health TRIGS grant. And then Adrian will provide a more detailed description of the methods and the people involved. And thank you, Colin. That was a really good background and introduction for what I'm now going to talk about. I also would like to pay my respects to the traditional custodians of the land on which I'm situated, which is the Pabalong clan of the Awabakal Nation, and pay my respects to elders past, present and emerging. And just a disclosure statement there, I've received no funding from tobacco or vaping industries. I'll start with a little bit of an overview of smoking rates in Australia, and this graph shows smoking rates over about a 20-year period from 2001 to 2019, and the purple line in the middle is the population smoking rate. And as you can see, we've seen a steady decline, and as Colin indicated, that decline's slowed down a little bit in the last few years. But what is particularly interesting to me is that there's a disparity in smoking rates depending on where you live, and using the Australian Bureau of Statistics CIFA codes to categorise areas according to socioeconomic status, we can see that the highest smoking rates in Australia are amongst or in areas that are the most socioeconomically disadvantaged, and the lowest smoking rates in Australia are in those areas with the sort of more advantaged postcodes and locations. But this only tells part of the story. And when you look more closely into certain subpopulations that are more severely disadvantaged, I suppose, I'm not sure whether that's the right term, but might be experiencing some comorbidities, and there might be cultural subgroups of society. You see that smoking rates just go through the roof compared to the general Australian population rate. One of the groups with the highest rates of smoking are people receiving treatment for opiate addictions, but also other addictions like alcohol and other drugs, or just alcohol, alone have very high smoking rates, and then some other groups here, and there's often overlap between these groups as well. It's a real complex problem. And this is the Australian data from a literature review published by Joe Geidish, you might know from the US, and it's smoking prevalence. There are Australian studies with people in opiate agonist treatment, and you can see that smoking rates range from about 70% right up to 95% of the populations that were surveyed. So very high smoking rates amongst people receiving opiate agonist treatment. And that results in high burden of disease. Just generally in Australia, tobacco is the leading preventable cause of burden of disease. And if you compare tobacco to alcohol and other illicit drugs, it's a much higher burden of disease. But if we look at people on opiate agonist treatment, there was an Australian study Louisa Degenhardt conducted, and it was a huge study, and the data goes back to the 90s and 80s. The most recent cohort included in that study was from 2000 to 2005, and they found that standardised mortality rates due to cardiovascular disease, cancer, chronic respiratory diseases, so all tobacco-related diseases are much higher amongst people on opiate treatment than the general population. And international data suggests sort of similar patterns and even higher patterns, and this is much more recent data as well, a study published only this year in JAMA Psychiatry. So tobacco-related disease is a significant issue for this particular high smoking prevalence group. And there's lots of benefits in addition to the health benefits for these guys. Like Colin's video indicated, you're changing lives by getting people off cigarettes. There's financial savings for the individual, improvements. Studies have found improvements in self-reported quality of life, financial stress, mental health, happiness. Smoking's a socially marginalised behaviour now. There's not many places where smoking's allowed, so it leads to further marginalisation and social isolation. And of course, with secondhand smoke and the high cost of cigarettes, there's improvements for the entire family when people are able to quit their tobacco smoking. And there's good interest amongst people in opiate treatment to quit. So this is just one study. There's a few similar studies that have found good numbers of people indicated that they're somewhat or very interested in quitting, and people, sort of describing their quit attempts over the last 12 months, making a number of quit attempts, and over their lifetime making a number of quit attempts. But quit rates are low, and high smoking rates amongst this population persist. So why is stopping smoking so difficult for this population when they are interested in quitting, and there are a variety of smoking cessation supports out there? There are some studies that have found that not just amongst people with in opiate treatment, but generally across population groups with very high smoking rates, that compared to the general population of smokers, they tend to be more heavily nicotine dependent, so they're smoking more cigarettes per day. They've usually started smoking at a younger age, making them more dependent by the time they're adults. And so they experience more severe withdrawal symptoms when they try to quit. There's also the whole social and environmental context of smoking. Almost everybody they know smokes, members of their family or their friends, and being social in sort of gatherings in people's backyards involves smoking. There are reports of lower self-efficacy or self-belief that they can quit. They're less likely to receive health provider behaviour to quit smoking. And there is some data that suggests that high levels of financial stress tend to undermine quit attempts. So even though you would think that the high cost of cigarettes would be a great motivator to quit, which it is for many people, but then if they relapse, they end up really stressed about it, and they end up buying cigarettes, and then fall into that financial stress cycle, and that leads to failed quit attempts. So quit attempts are made, but they're rarely converted into long-term abstinence, which is what we really want, and that's long-term abstinence from tobacco cigarettes. So as Colin indicated, vaporised nicotine products and vaping presents a potential harm reduction approach, and might be an alternative to smoking cessation if people can't or don't want to quit nicotine entirely. The tobacco harm reduction aims to reduce the morbidity and mortality and the impact on a person's life without them going completely nicotine abstinent. And the idea of harm reduction, as you would all know, is well established in drug and alcohol and some other clinical settings like HIV treatment. The harm from tobacco smoking comes from the products or the toxic ingredients in the products of burning the tobacco in the cigarette, and this might offer a cleaner source of nicotine for people. And there's pros and cons, and there are hundreds of articles published about vaping and vaping products every year now. And in general, what that research is suggesting is that it looks like it is a cleaner source of nicotine than tobacco cigarettes, making it a safer source of nicotine. And economically, it's cheaper for people to vape than it is for them to continue smoking. It provides the potential for people to still be part of those socio-behavioural elements of smoking, so they can vape together rather than smoke together, and also the hand-mouth movement, that behavioural aspect of smoking and doing something with your hands is still present with vaping. It addresses the nicotine withdrawal effects, and so far studies suggest that it's quite attractive to smokers, so they're more likely to stick with vaping. Many of the nicotine replacement therapies or other stop smoking medications suffer from a little bit of low adherence, affecting their effectiveness of helping people quit. And it might be viewed as an interim step towards abstinence. So somebody, might get off the tobacco cigarettes and vape for a while, and they might vape for a really long time, and they might stop vaping as well and become completely abstinent from nicotine, or maybe they won't. But there's some drawbacks, and again, Colin indicated that there's limited research still, despite all the hundreds of articles that are being published. A lot of that research is quite rubbish, and we need more quality research on the benefits and particularly the long-term harms of e-cigarettes. And as a scientist, Paul described all the speakers tonight as being pro-vaping, but as a scientist, I'm actually just after the data, and I want to know what the actual answer is around vaping. I'm hopeful that it will help people, but I need more evidence and data to be certain that it will. Some people report that e-cigarettes could be difficult to use, particularly the tank devices that require them to measure out liquid nicotine into the tank devices, and to remember charging their device. And this is a particular issue for people with serious mental health concerns. And of course, the regulatory environment at the moment in Australia makes sourcing liquid nicotine very challenging for people. And there are a few trials, as Colin indicated, but there's not an awful lot of data, and these trials suggest that that vaporized nicotine products might be effective with helping people quit smoking, but there's not an awful lot of evidence in groups with a high smoking rate, so people with mental illness or people in drug and alcohol treatment, for example. And that's what I'm really interested in, is assisting those people who are finding it particularly difficult to quit smoking. The studies that do exist are very small. There's one study that with people with mental illness, it's a secondary analysis of of Chris Bullen's big randomised controlled trial, so that's a little bit dated as well. And then there's a few before and after single group studies with people in alcohol and other drug treatment. Two of those are with people with opiate addictions, and the sample sizes in those studies are very small. There's no control groups. There's a variety of different types of devices and nicotine concentrations used, and there's no evidence in them, assisting these particular populations with smoking cessation, but they do report positive outcomes for things like reductions in the number of cigarettes smoked per day, or treatment adherence and the acceptability of using the product. So it's sort of, this led us to think, look, vaporized nicotine products might be a good option to trial for people in opiate agonist treatment. So what we did was we conducted our own small little pilot study in 100 New England opiate treatment service, and we recruited 60 participants, 50 from the opiate service and 10 from the cannabis counselling service as well. And we conducted a little randomised controlled trial where everybody received a vaporised nicotine product and a 12-week supply of liquid nicotine. And then we randomised them to either be told that they had to follow an abrupt cessation protocol where we set a quit date with them that was 2 weeks in advance, and they could smoke up to that quit date, and then they had to quit smoking on that quit date, but they can continue using the vaporised nicotine products. Or the other group was randomised to a gradual reduction schedule where they were asked to reduce the number of cigarettes they smoked per week by 25%. For 4 weeks until they reached the no cigarettes week 4. And we did that in order to get a better sense of if we're going to run a big trial with vaporized nicotine products, what's the best advice that we can give participants in the trial as to how to stop smoking and transition to vaporized nicotine products, and we thought that pilot might give us a little bit of data about that. And we had a 12-week follow-up, and we assessed CO verified cessation, reductions in cigarettes, adherence, and the acceptability of the vaporized nicotine products. And at 12 weeks, we had 52 people out of the 60 followed up, and we did some qualitative interviews with participants as well. Really sorry about the quality, but this is just your basic randomised control flow chart to show you how people were allocated either to abrupt cessation or gradual reduction, and then surveyed a couple of times until the final follow-up of 12 weeks. So these are the cessation results, and these haven't been published yet. We're just in the process of writing them up at the moment. But basically, between the two groups that people were randomised, we didn't find any differences in self-reported 7-day point prevalence, abstinence, and this is in all cases it's abstinence from tobacco cigarettes, and whether that was intention to treat analysis where we treated all missing data as continued smokers or just complete cases. The CEO verified 7-day point prevalence and then 6 weeks continuous abstinence at the 12-week mark. So there were no differences in cessation rates between the two groups, but the cessation rates were quite high, like, encouragingly high at that 12-week part. So these are people who were using vaporized nicotine products rather than tobacco cigarettes, and in a lot of cases, around a third were saying that they quit smoking. In terms of reductions in cigarette smoke, for those who were still smoking, we found significant reductions from about 23 cigarettes per day at baseline down to 9 for the gradual reduction group and 6 for the abrupt cessation group. So again, that's fairly promising. In terms of adherence to abrupt cessation protocol or reduction by 25% for 4 weeks, we surprisingly found more people say that they stuck with their quit date in 2 weeks' time and just used that, and a lower number of people did the 4-week gradual reduction schedule. So, and in terms of acceptability, this is some of the quotes that we got from the qualitative results. This person says, I've tried quitting patches, gum, even shampoo, Zyban and stuff like that. I have to admit, initially I didn't think that e-cigarettes was going to work. I had serious doubts about it. But on day one, I felt that when I used it, I didn't have the cravings to smoke a real cigarette anymore. It's not like you're stepping away from cigarettes as much as it's more like you're still getting your nicotine, you're still getting that hit that you yearn for in your head. So it's not really swapping, it's not giving up one for the other. It's more like a general step down from a cigarette to an e-cigarette. I think it's the product itself. The liquid comes with the nicotine in it and help the cravings, the physical and psychological thing of having something to your mouth, inhaling, blowing out, basically the trained thing that all smokers do. It still gave me something to compensate for that cycle. So we got some good acceptability results. So all these results were quite promising. So in the end, and this is the last slide, I promise, with such unacceptably high smoking rates amongst these particular population groups and high burden of illness, and their genuine interest in quitting and yet low quit rates, we thought was good enough rationale to do something, and our pilot study suggested that vaporized nicotine products were acceptable. We had good rapid recruitment and high short-term retention of participants in the trial. Some suggestion of short-term cessation and reduction in cigarettes, and a greater compliance to the abrupt cessation than structured gradual, but no real difference in the actual cessation rates between the two groups. So we thought, whatever consumers' preferences were about the way that they quit could probably be recommended based on those pilot results. And I'll throw over to Adrian now.
Before we go further, Adrian, there've been a couple of questions online. Are you okay for Billie to answer a couple of questions?
Absolutely.
Billie, since you're a scientist, very interesting data and a great talk. I mean, I was really challenged by the fact that the qualitative information was that they loved the vaping, but they kept smoking. Like, it didn't help them to stop smoking. So if they loved it, but they didn't quit smoking, did they really benefit from it?
Yeah, so we think they did, because the smoking cessation rates were quite high for this particular population group. these guys have a quit ratio close to 0. You know, most don't quit even with NRT and all sorts. So getting between, you know, 20 and 30% quitting at 12 weeks was a good result, regardless of, you know, the abrupt or gradual cessation. And then for the rest of them, they had reduced the number of cigarettes that they were smoking quite significantly, from over 20 to less than 10. And what we're really starting to think about smoking with these groups is that it's a long-term process that people need to be supported through, that it's not a right, today I'm going to, you know, quit and then that's it, they'll be quit. It's more a case that they will probably quit, relapse, reduce, and eventually get to quitting long term. So, you know, what we're wanting to do is longer term follow up and see, you know, whether those quit rates increase longer term with them using the VNPs as an alternative to tobacco cigarettes.
Thank you. The other question that was put to me in the chat was about asking, why was the abrupt group more successful, do you think?
Yeah, look, that's really interesting, and it surprised us, that result, because we've done a lot of work with smokers who tell us that they prefer to gradually reduce the number of cigarettes that they smoke. So we've always gotten this data that suggests that gradual reduction is the preferred method. The fact that more of this particular sample wanted to just quit on a given quit date suggests to me that that might be related to the use of the VNP, the vaporized products, perhaps, like that, you know, that we've given them a viable alternative to tobacco cigarettes. And so it's a lot easier to switch from tobacco cigarette to an e-cigarette than it is to go from a tobacco cigarette to a nicotine patch, or, you know, something like that, where someone might want to hold on to their cigarettes for a little bit longer and gradually reduce.
Yeah, I see what you mean. It's sort of like if you're going to take up jogging, you either buy a pair of shoes and start jogging, or you don't.
Yeah.
And I know which group I'm in, but look, I think I understand that. That's great. I think if there are no more immediately pressing questions and there's nothing in the chat, I'll hand over to Adrian to give his part. But does everybody know how to use chat? We're not getting a huge amount of chat. You know, there's the little chat icon at the bottom of your screen. So you go click on it and start typing. So please feel free to do that, because I think then I can put your questions to our illustrious speakers and get their feedback. But let's hand over to Adrian now. Thank you, Adrian.
Thanks, Paul. And I wouldn't mind coming back just to, you know, your first question to Billie. In the drug and alcohol field, you and I, at least, have got pretty low standards. Like, we get pretty excited by reductions in drug use. Abstinence is a high watermark. Abstinence is hard to achieve. So that's why, you know, seeing the data, the preliminary data that Billie showed that we did at the Newcastle clinic, we were very excited about that, actually. So a number of people did stop, and a number of people cut down pretty substantially.
Do you mind if I respond to that? Because I think there is first of all, there's no doubt that you're right, that people with drug dependence are struggling with their drugs, and they may want to reduce their use, but getting people to stop completely their alcohol, drugs, smoking is hard. And it's not always necessary. So you were on a teleconference this afternoon where we were talking about cannabis, again, with cannabis and with alcohol, there's very clear evidence when people substantially reduce use that they will benefit tremendously. But with respect to tobacco, there's actually quite good evidence from some of the large BMJ papers that you read that actually even small amounts of ongoing smoking continues to be very harmful with increased risks of tobacco-related mortality. So I think tobacco might be a little bit different from some of the other stuff because the product itself is poisonous. So I just...
yeah, fair call.
There's something in common in terms of people's attitudes, but there's something different about the product themselves. But forgive me for editorializing from the chair, and let's go back to Adrian.
Okay, so I'm going to do part 2 of Harmony, the second part of Harmony. I'll just get now. Can I check? Is the screen viewable to everybody? Paul, can you tell me if it's...
Sorry, yes, I put myself on mute. Yep, your slide.
Wonderful.
Great.
Thanks. So I don't have a disclosure slide, but just to start, I don't receive any funding from tobacco or e-liquid, nicotine liquid companies, and they're not involved in this study. I'd like to start by acknowledging Billie. Billie certainly did a whole bunch of very important work in helping put this grant together, and it was successfully funded by New South Wales Health as part of the Translational Research Grant Scheme. I'd like to also acknowledge all my co-investigators. Paul's up there, Nick, Nadine, there's a bunch of others who are going to be involved in us rolling out this study. So the study design we're going to do, it's a 2-arm parallel group, single-blinded randomised control trial comparing 12-week of liquid nicotine using a vaporised nicotine device to nicotine replacement therapy. It's going to be a 12-week intervention with a 12-week follow-up. And it's a multiple site study occurring across 6 local health districts in New South Wales, being Hunter, New England, Southeast Sydney, Sydney Local Health District, Western Sydney, Southwest Sydney and St Vincent's. And we're planning to recruit 572 participants to the study. Inclusion criteria being an adult, currently on opiate agonist treatment, either methadone or buprenorphine from one of the services who are participating. Being a current daily smoker on wanting to quit or cut down. They don't have to commit abstinence to be eligible. Quit or cut down tobacco smoking and be willing and able to comply with the study requirements. The exclusion criteria are current regular use, so more than 1 day a week of vaporised nicotine over the past month, breastfeeding or pregnancy or planning to become pregnant, current severe medical disorders, for example, unstable cardiovascular disease or peripheral vascular disease or poorly controlled hypertension, current severe unstable psychiatric problems, so for example, acute psychosis, severe anxiety, intent to harm self or others, involvement including on other drug use. So we don't have excluding people using other substances, or there's no minimum criteria for use of other substances. So we're trying to get a representative sample of patients on opiate treatment. The vaporised nicotine group will receive the Inokin Endura T18-2 starter kit, and there's a little picture of it on the side of your screen. And they'll receive a 12-week supply of prescribed nicotine e-liquid. We're using the UK and the Ireland source. And each week they'll get 2 10ml bottles at the 12 milligrams per ml strength of liquid nicotine, and they'll get a month's supply, and we're accessing this through the TGA CTN scheme. They'll also get 1 week startup nicotine patches, because we know that people take some time to learn and develop how to use liquid nicotine. So that's for the first week of their treatment, they'll have that as well. And education materials in how to use liquid nicotine by vaporizer effectively. The comparison group, the NRT group, will receive patches plus another short-acting form of liquid with nicotine, again for 12 weeks. So patches plus a combination of inhalators, lozenges, gums, oral mouth spray, and again, information on how to use. I've got the picture there for Nicorette, but we won't exclusively be using Nicorette products. We'll be using a range of different ones. So the primary outcome is comparison of vaping versus NRT groups in self-reported 7-day continuous abstinence from tobacco smoking at the completion of the 12 weeks of the treatment phase. Then our secondary outcomes are biochemically verified 7-day continuous abstinence from tobacco at the end of treatment, using a CO monitor and having a cutoff of vape parts per million. We'll also look at secondary outcomes of self-reported 30-day point prevalence abstinence from tobacco, as well as 30-day point prevalence abstinence from all sorts of nicotine products at 12 weeks post-treatment. And then we're also going to look at adverse events in both groups, number of cigarettes smoked per day at baseline, end of treatment, and 12 weeks post-treatment, and nicotine craving and withdrawal symptoms, again at baseline, end of treatment, and 12 weeks post-treatment. We're going to look at number and duration of tobacco relapse episodes at the end of treatment and at 12 weeks post-treatment, and tobacco treatment adherence at the end of treatment, and then the use of vaporized nicotine products, or NRT, at 12 weeks post-treatment. So that's after the 12-week treatment phase. And then we will look at other substance use, self-reported other substance use at the end of treatment and 12 weeks post-treatment to ensure that people aren't substituting other drugs for tobacco use if they've decreased their tobacco use. We'll research study retention at the end of treatment and 12 weeks post-treatment, as well as having a cost-consequence analysis, the effect being the proportion of self-reporting 7-day point prevalence smoking abstinence at 12 weeks, and look at costs of the vaporized nicotine products and NRT and clinician time related to that. Patients will participate in pre-screening visits, and then there'll be baseline week 4 and 8 visits, and they'll receive the nicotine products at those 3 visits, so the baseline, the week 4 and week 8. And then the week 12 and 24 research follow-ups will be single-blinded, so the researchers doing that part will be done via telephone and will be blinded to the patient's condition. We did present this group, so recently the Drug and Alcohol Clinical Research and Improvement Network, so that's the LHDs plus a couple of other LHDs who have more recently joined that, Central Coast, Illawarra, North Sydney, Justice Health have joined more recently. So they've put together for the first time a consumer advisory group to get consumer feedback on the study. And even though the study had been substantially under development, we thought this was a good opportunity to get some consumer feedback. So we presented the study to them. Mel Jackson is working on the study, presented this with me a couple of weeks ago. And their feedback was, it was rated as being very worthwhile with the use of relevant resources. And they gave it, out of a 10 out of 10 score, they gave it an 11 out of 10. They thought it was important that there was a clear understanding of the high prevalence of an extensive tobacco use in this group. They talked about their own lived experience of vaping for smoking cessation and endorsed the choice of unflavoured e-liquid for the people in the vaping arm. Sorry, wrong way. In terms of particular concerns, they discussed with us ethical concerns about the study given the unknown long-term effects of vaping, so we did discuss that. They talked to us about post-trial support and asked questions about why the NRT arm were not being given access to vaporized products post-treatment. And also made the comment, and I think Billie alluded to this earlier, that maybe 12 weeks is not going to be long enough to get sustained benefit from vaporized products. In terms of suggestions, particular suggestions they gave were to consider including more objective biological outcomes other than only carbon monoxide levels. So we've starting some further thinking about that, to provide advice about how to legitimately buy e-liquid after the 12-week treatment for both arms. They very strongly gave us feedback saying they thought that supermarket vouchers were inappropriate and belittling for this group, and they preferred cash reimbursement, or they suggested cash reimbursement was more appropriate. And then they also provided results to the community advisory group on feedback and how to incorporate suggestions. So the main ethics submission's been made for the study. We're now responding to inquiries. We do plan at this stage, depending on when we get the clearance from ethics and go through the SSAs, to commence early next year. We're going to have a 12-month recruitment period for each site. And so we aim to complete data collection by roughly June 2022 and finish by the end of 2022. Thanks very much, Mel, who helped throw together some slides for tonight. And again, I'd like to thank Billie for her role in the trial. Jane Rich from Newcastle Uni has also helped develop the study to now, and there's a study-specific email there for folks. That's my presentation, Paul.
Adrian, thank you very much. That's really, really great. And obviously a large group of people that you're working with. And we look forward to both participating in the study and to see what Newcastle University ethics are going to say about it, because they're not always easy.
Oh.
Does anyone have any new questions? I'm not seeing anything in the chat. So I think since we're just starting to slip a little behind time, we'll come back to that in the general discussion, but allow Carolyn Beaumont to give her presentation now. Carolyn is a GP from Victoria and is one of very few doctors that is actually prescribing these products and has some familiarity with it. And so I think it's really great to hear from her to give a practical perspective on how we use vaping products.
Hey, thank you. I'll just get this set up. Okay, is the screen coming up?
Yep, perfect.
Excellent. Okay. Thanks everyone. Thanks for having me along. And yes, so I'm one of a few GPs who've publicly put my hand up and listed with the ATHRA website. I've only started prescribing this year, and I have been an absolute newbie at it, and I've been on a very steep learning curve. So I think the first point I'd like to make is that don't worry if you don't know anything about it. Hopefully this presentation will be fairly practical. We'll give you some online resources, some tips about things. And look, essentially I found the best way to learn about it was simply to open my book, start prescribing, and have the most amazing conversations with, generally ex-smokers who have changed over to vaping. So they've pretty much taught me everything. Colin Mendelsohn has also taught me a great deal. So many, many thanks to Colin. He's been very, very patient with me. So starting off, so these are the topics I'll be going through. And I know you can all read, so I won't read it out to you. Okay, so let's get started. Hang on, so I just need to fix something with the screen. There we go. So look, as you probably know, liquid nicotine, or e-nicotine, some people refer to it as, it's not available in Australia. All other parts of the vaping device, so the flavours, the actual product, the device itself, you can get that from Australia at stores, in-store, online. And as Colin was saying before, you need a script from a doctor, and it needs to be for medical purposes, not for recreational purposes. Although I think that line can be quite blurry. And the main thing I do is that in my notes, I meticulously comment that they do have a nicotine addiction, and this is needed to keep them smoke-free. If they happen to enjoy that, by the by, that's not for me to comment on, and more power to them, really. So they can order the nicotine overseas from New Zealand or the US are the most common sites. I generally just recommend New Zealand sites. We have probably slightly more reliable, transport time, etc., etc. As you've been told before, that you can import up to 3 months supply. Importantly, there's no upper limit on how much nicotine you can prescribe for someone. Essentially, it's based on their own use and their own needs. And as long as a doctor, you're satisfied that that's an appropriate amount for them, then that's all you need to really document. And they can import up to 15 months supply in 1 year. And that's just to allow for, sometimes they might need to order their next 3 months a little bit earlier, a few things like that to give a little bit of wiggle room. So how to get started with prescribing. So the first thing is to get the vaping community to know that you're available. So I found just by listing with ATHRA is the best way. Most of the vaping forums are aware of ATHRA and direct vapers that way. Obviously, the benefits of ATHRA, it's a very legitimate site. I try to stay far away from general vaping, social forums. I think, just being sort of conservative in that aspect and keeping any online associations very professional, really. I write a handwritten script and then I email a copy of that to the patient. And you can choose which method of billing you want to do. I started with a mixed billing. I've now changed to a fully private through my own website. Just give me 1 moment. Okay, so just running through go away, Siri. Siri's not involved here. So just going through how I started prescribing. Initially, it was just through my regular daytime practice, and we did a mixed billing approach. The patient was $60 out of pocket, and then we billed the appropriate item as well. And initially, I started giving them a 12-month script, so 3 months supply with 3 repeats. Probably after a couple of months of doing that, I decided just to change to giving them 6 months, so 3 months with a repeat. The important reason is to be able to demonstrate ongoing review to reduce nicotine use. And a lot of that is really driven by, we don't really know the political climate. In a way, every, every consult note that I write, I have to assume Medicare or TGA or customs are also leaning over my shoulder and reading everything. And so I just have to be, I think you have to be very, very cautious, really be towing the line. Maybe picture Greg Hunt is there next to you as well and just giving a nod for everything. So we can always pull back from that a little bit, but yeah, it's important to make sure you don't draw attention to yourself in any way. You know what I mean? And then I decided after a few months to change to my own personal website, which is fully up and operational, and you're very welcome to hop on and have a look at it. I found it worked better essentially because the daytime practice, we were just getting inundated with vapors, and my other patients didn't get a look in. So this was just a better way to do it. I'm still toying around with that a little bit, but it seems to be working well so far. Okay, the fun stuff. So firstly, what sort of patients? Well, ideally, they already vape and they know what they're using and how much and how long a bottle lasts and what brand, and it's very easy to have a nice straightforward consult with them, write a script, and you're done. But the reality, it's probably a bit more like this, and I am getting a lot of new vapers and they really don't know where to start. All they know is that they want to stop smoking and they've tried everything. So they need to know about the device, and you can't prescribe for them until they've chosen a device, because that's an integral part to the concentration and volume of nicotine. So the best thing to do, I find, is myself as a non-smoker, a non-vapor. So for me, a lot of this is theoretical knowledge. So I say, look, have a look online, go to some good forums, go to a store. The link here, Aussie Vape Stores, that lists all of the vape stores in Australia. So basically, any of the shops are very, very welcoming. Anyone can just give them a call, drop in, etc. And they'll be able to play with the devices, work out sort of where they're at with things. The other thing in terms of patient selection is that at the moment, my choice is that I don't prescribe to under 18-year-olds. I think, again, just not really knowing maybe how acceptable it would be. Again, picturing Greg Hunt over my shoulder. Not, I think it's a bit hard maybe to demonstrate a serious nicotine addiction where all other possibilities have been exhausted if they're under 18. But actually, I think I've only had one person who's 19. Actually, that's the youngest. The majority of my patients are well over their 30s, generally probably 40s to 60s, I'd say, are my most common patients. They've smoked for most of their life. Nothing else worked. So to get started, you'll need resources, and lots of them, but you don't want to be overwhelmed with things. So the top 3 that I've listed, obviously the Atherosite, and as you can see by the diagrams at the bottom, there are 2 Atheras. So make sure you go to our Athera, not the Australian Trail Horse Riders Association. It's amazing how often that one comes up as well. The second site, the Vaping 360, that has a fabulous article, and it's not too long, and I've given you a screenshot there. That's just all about the different types of nicotine and strengths. Highly recommend that one. And the third one, Vaporised blog. Again, that's very useful, and I think I refer to that a bit later on. Then the bottom 4 are just probably 4 of the more common New Zealand sites. So I think keep it simple. Just have, even just have 1 or 2 favourite sites, and their products. And if someone doesn't quite know who to order from, just say, look, these 2 sites are good. These are their products. Okay. Now, the main thing really is in terms of how much nicotine, the strength and the volume. So the first point is what I've written at the top: don't try to convert the current cigarette strength to the e-nicotine. That's the trap I fell into initially, and it got very difficult. And as Colin pointed out, one of the many things he's pointed out to me, it really can't compare at all. So the absorption, the blood levels of the nicotine in cigarettes is just totally different to in vaping. So essentially, I just break it down again, like to keep it simple. Is the smoker a light, medium or heavy smoker? Basically, you can ask things like, are you just a social smoker? Or medium, do you maybe smoke 10 to 20? Heavy smoker, more than a pack a day. And also the degree of nicotine addiction. So really, how long after awaking is your first cigarette? So finding out, how heavy a smoker they are. Also, the next one is the device type. So there are 2 types, there's pods or tags. Pods you can buy pre-filled, little cartridges, there's an image later on, or refillable, or the tank. Now, they might not know much about these. I'll give a little bit more information soon. They can also talk to their friendly local shop. The third one is how much cloud that they want. So you might have seen some vapors and there's a massive white cloud around them, beautifully scented. So some devices produce that, and others you don't even know they're vaping until you walk past them and see the little device. So I don't find that such an important aspect with new vapors, but for some people it might be. And the fourth one is what sort of draw they want. So the next slide talks about this, about direct to lung and mouth to lung. So that will also determine the type of device they order, which then determines the type of nicotine you'll order. But I've put here, reality is don't get too involved with all of these specifics. Just be aware of the concepts, because they might talk to you about direct to lung, mouth to lung, draw, cloud, throat feel, etc. It's not really your job to have to sort that out for them. Refer them to a store, and then just get them to contact you again when they have chosen a device, and then you can move on. So a little bit about the devices. So we've got pods, so pre-filled or refillable, up to a 3 ml capacity, and they're nice little devices, little things like this. That's one of the Juul JWL, very popular pod device. They come in with little packs of 4 pods. They're pre-filled from memory. Really nice, easy way for people to start. One of the issues with the refillable pods is because they're pretty tiny. Some of them are even only 1.7 mils. It's tricky just to maneuver and manage, that sort of thing. Or people can use tanks as well. They're bigger. That's often for the people who want to get a lot more of the smoke and inhaling sort of the direct to lung, usually up to about 5 mils. Occasionally there's big 10 mil tanks, but they're quite uncommon. So the nicotine essentially is available in 3 options. The commonest would be for the person to buy it already pre-mixed in the pre-filled pods. So that would be like these little Juul pods. That's the easiest way to start. So there's no mess. You don't have to think about the concentration. You just put it in and off you go. And then people will buy the pre-mixed nicotine for the tanks and refillable pods. It's reasonably common. And some people are a bit more experienced, like the real DIY option, and they'll buy the nicotine concentrate. And that will be usually for their tanks, some refillable pods. That does work out to be a lot cheaper. So often people will start off with the little pre-filled pods and eventually work out what they like and go on to the concentrate. But that might take a year or 2 of sort of working out what really suits them. Okay, so I mentioned before about direct to lung and mouth to lung, and Vaporised, so the blog I mentioned earlier. So this is a very nice little article about it, and I really only became familiar with these terms probably a month ago. But essentially the mouth to lung type of device, it's the one that replicates the feel of cigarette smoking a lot more. So it's good for the new vapors. So they inhale it, hold it in the mouth, and then it's fully inhaled to the lungs. So it's a more popular device. You'll hear more about high resistance, low resistance, sub-ohm, etc. So this is a more high resistance call. So they've got to suck on it quite hard, and it stays in the mouth first, and less cloud production for them. Direct to lung is basically very low resistance device. They just inhale and go straight through to the lungs. They get a much bigger hit, and you get nice big fumy clouds because they're inhaling lots and lots of vapor. And so I think this bottom line is cut off. I've just written device types, refer patient to the online resources and shops. Okay, salt nic and freebase nic. So it's not complicated. It's essentially, it's just the 2 forms that the liquid nicotine comes in. So firstly, the image down here, I think that's from the Vaporised blog, I believe. But essentially, the salt nicotine or protonated nicotine, it has an acid, it smooths out the throat sensation. So it means that people wanting a stronger, wanting or needing a stronger nicotine hit, they'll tend to use a salt nic, because otherwise if it's the other sort, the freebase, that's a bit too harsh and you get this unpleasant throat hit, they call it. Some people call it throat feel, throat hit. So the salt nicotine, essentially because it can be a more concentrated one, that becomes synonymous with pod systems. So the small little cartridges have the concentrated salt nicotine in it. Typically using the pod systems, which have small capacity, small power, low vapor output. And the pod devices need the high concentrations because they only have 1.7 mil, 2 mil capacities maybe. So salt nic is available up to 50 milligrams per mil. And because pod systems are nice and they replicate cigarettes, we tend to recommend pod systems and therefore salt nic for beginners. Freebase nicotine is cheaper and it gives a nice big cloud, but it's too harsh on the throat above strength of about 18 milligrams a mil. Commonly that might be say 3 to 6 milligrams is quite a common strength, sometimes even very low, 1 or 2 milligrams. And it's good for the tank systems, apparently. I'm again, I'm not really an expert on a lot of this, so they can refer a little bit more to some of those online resources to find out more about freebase and why you would use that in the tank systems and not the other one, etc., etc. Okay, talking to them about duration of use. Look, the big thing I've found is that don't worry too much about how long they're using it for. All we want to do is to stop them smoking. So the best nicotine strength is the one that keeps you smoke free. And I tell the patient that they may never be completely nicotine free, and that's okay. The nicotine addicts, but the tobacco kills. So we're getting rid of the tobacco. So just aim for the lowest sustainable strength possible, and sustainable as in they're not going to relapse and go back to smoking. So if they need a higher nicotine dose, or if they stay on that high nicotine dose for months or years, but they're not smoking, that's fine. That's fine. Just go with that. Just, mention, look, if you can gradually reduce down, that's fine. But the main thing is to stay smoke-free, and which is the third point. So don't push them to reduce the nicotine strength too quickly. Sometimes I'll end up compensating by inhaling it more deeply, which just puts them at greater risk of some of the other potential toxins in the device, even though obviously they're a lot less than in cigarettes, but it's still better just to have that higher level of nicotine if needed. And also so they're not sort of chain vaping because they just can't quite get enough. Okay, so correct device use. Some of the issues that arise will be about leaking. That's often to do with the smaller refillable pots, just because everything's so little, really. They sometimes find it hard to tighten properly, etc. They're difficult to refill, battery life, refer them onto the shops. And as I said before, aiming to not chain vape, but you might need to step up, they may need to step up the nicotine strength. So consult. So I find in general, these questions just guide things pretty well. One thing I'll point out, and again, I credit Colin for letting me know all about this one, is that with their medical history and their current medications, is that the polycyclic aromatic hydrocarbons in cigarettes do induce cytochrome P450-1A2, which metabolizes many drugs, and some important ones are olanzapine, clozapine, warfarin, and caffeine. So there is, when you change to vaping, there's risk of increased serum concentrations. So that's probably a really important one to point out. And also with the caffeine, suggest reducing caffeine intake maybe by up to about 50% when they're changing. But again, once they get going with vaping, they find their own happy medium with things like caffeine. Okay, so smoking history. Probably the most useful thing I find with the smoking history is how addicted are they, as in the time to the first cigarette. I mean, some people say they wake up during the night because they need to smoke. So that's addicted. Some people, as soon as they wake up, they need to smoke. Others, they're fine. Maybe they just have one when they get to work on their break. So that's an important one.
Caroline,
Yes.
I'm sorry to butt in.
Yes.
How much more time will you need?
Oh, okay. Quick.
You've
Okay, so I think I've gone over this one and just a few examples of scripts. So yeah. I love this one. These are direct quotes from the patients. I'll leave you to read those ones. And the last 5 slides here are just some of my actual scripts, and it just shows the variety. So we've got the pods which come in the 1.2 mils. That's just that particular patient's one. Large volumes, 1.5 litres, that would be for a tank use. Another one, this shows the concentrate, 100 milligrams a mil, 50 mils, usually 100 mils, but depends where people supply it from. And that's it.
Thank you very much. Can I just
explain it there?
Yeah, no, that's fantastic. What the key thing, really practical, but as I understand it, the key thing is they have a prescription, but they don't have to show that to anyone, do they?
That's correct. So
tell us what they do with the prescription.
Yeah, they basically just keep it on their phone. So when they go to order from overseas, they don't need to show a prescription. So they can go through the whole ordering process. The moment it hits Australia, though, and goes through customs, they may need to show the script, but customs will contact them in that case. Now, to my knowledge, there have been a few cases already of customs refusing to release the goods because they can't show a script. And when that happens, the person can then potentially be charged with trying to import and possess a banned substance. So it gets pretty serious. I haven't come across any cases of people just happily vaping down the street and then being pulled over and having to show the script. So I think it's mostly just at the point of import.
Right. They have to keep it. They have to have it, they have to keep it, and they have to be able to show it if
that's right.
Guy.
Yes, exactly. And I keep the hard copy at my practice, and that's also evidence that they haven't tampered with the script, so they only have a digital copy. But that's also because my prescribing is solely online. So I have telehealth all around Australia. So it's very rare that I actually get to meet the patient. It's only if they happen to live locally to my practice and happen to work out that I also practice there. So yeah, I found that works.
So I'm just waiting for people to type in their questions, and I'm just having a look here. So you require, just to restate what you require, because like if I ring you up and ask for a script, what are the key things that I have to satisfy you before you do it? Or do you just kind of...
No. So firstly, what else have you... Well, the first thing is, are you a current smoker or an ex-smoker who's already changed to vaping? And I get about probably 70% have already vaped for months or years, but about 30% they've heard about vaping, but they didn't know where to start. So look, the first thing is, let's talk about the new vapers. What else have they tried? And that's a really big part of things. So, most commonly they'll have tried all of the other NRTs, they'll have tried Champix, counselling, hypnosis, and most commonly nothing will work. Sometimes some things work, and we explore that a little bit more. Sometimes, for example, Champix has worked for a few months, but then they relapse. And generally, I would like them to demonstrate that they've really given the other therapies a good go. And then we talk about how addicted they are, what are the withdrawals they get, why do they want to change as well, what's their motivation, and yeah, then once we've established that, then we just go on to the sort of the nuts and bolts of working out about the device and the nicotine strength.
Okay, so can we just, someone's asked the question, and you have actually answered it in your talk.
Yeah.
But they've asked again, and honestly, I couldn't answer it myself. So good to hear you restate it. How does your GP know what to write on the script in relation to the nicotine strength? If you decide that I'm a heavy smoker, middle smoker, or light smoker? I think you told us about that.
Yes.
But for those three categories, what do you write on the script?
So I guess let's assume that it's a new vapor, because the easy patients are those that have already been vaping for a few years, and then they call you because they say, oh, I've heard I need a script. So they know exactly what they're using. They know, for example, that they order 6 milligram freebase pre-mixed in 30 ml bottles, and they go through 3 bottles every 3 months, for example. And it works beautifully for them, and they've never returned to smoking. So they're the easy ones. You basically just write the script. So for the new vapors, so the first step is that they need to know what sort of device they want. And that's where I think on one of the slides I was talking about, there's how much do they want it to replicate real cigarettes? And generally speaking, that'll be the pod system, higher resistance ones that have more that initial mouth to lung with that initial mouth draw, and then it goes into the lungs. So once they've worked out their device, and often we have an initial conversation just about establishing previous attempts to quit, how addicted they are, why do they want to stop, what do they want to get, what sort of device can they picture. you know, some people just want a tiny little thing to put in their handbag. Others like to have a nice big tank that they can have clouds around them. Some people have both devices. So if they really don't know, I say, look, here's some resources, go to chat to some local stores, look in some forums, then come back when you've worked out a device. Once they know their device, I would suggest, let's assume it's a pod. So, for example, the dual pods. So I think they're 1.7 mil capacity from memory. Sort of a medium strength would be, I think, a 6 milligram pod. So what you can do is say, look, we're not sure exactly what strength is going to work for you. Now, what I didn't show on the scripts is you can do a range of strengths. So, and this is where you can go online and find out from one of your couple of what they provide. But I think, for example, you can buy dual pods like in 3 milligrams, 6, maybe 9, I can't quite remember if it goes that high. And say, look, just put on the script, say 3 milligrams up to 9 milligrams of dual pods. They come in packs of 4 and supply, say, 60 of them. And that'll get them going. And I suggest to them just order a few of each, play around with it. And it might take a couple of months to sort of work out. But yeah, really sort of stress that point that it is a little bit of trial and error initially. But essentially, if you think in terms of the free-base premixes, which are quite common, so people will use them to fill up their little pods or their tanks. Okay, high strength is 18 milligrams. Medium is sort of 6 to 12 milligrams, and then quite low is maybe 2 to 3 milligrams. So if you just think, 12, 6, 3, heavy, medium, light, that's a reasonable starting point. And yeah, just put a range of concentrations on it.
Thank you.
Great. Yeah, I hope that answers a bit.
Billie, you have to unmute because I'm going to ask you the next question. You're a researcher and a scientist, and you're doing research because we don't have enough data about safety and efficacy of these products. What do you think about doctors writing scripts for anyone who rings in after answering some questions, but for anyone that rings in to request it? I'm going to ask Adrian the same question so he can practice unmuting too.
So Paul, there is a reasonable amount of data on safety that suggests that compared to tobacco cigarettes, e-cigarettes are safer. So they're not completely harmless, but they're much safer than tobacco cigarettes. So if the choice is between continued tobacco smoking or e-cigarettes, obviously I would support e-cigarettes because the evidence, that relative safety evidence is there. And certainly as far as the randomized controlled trials that have been conducted with vaporized products, there's not been any safety issues related to the products identified in those trials. So I think the biggest concern around safety is really about long-term safety, whether using e-cigarettes or vaporizers for 20, 30, 40 years. We don't know the answer to that yet. But at this stage, based on the weight of the evidence that we have today, it's much better for someone to use e-cigarettes than tobacco cigarettes.
What do you think, Adrian?
I wouldn't be too concerned, Paul, really, if somebody was unable to stop otherwise and wanted to try vaporized nicotine. I think it's a pretty reasonable thing to do, given the known problems with tobacco and a very wide number of acute and chronic problems. I think it's a pretty reasonable strategy.
So, I mean, I hate to play the devil's advocate, but if we're all so comfortable to proceed in the selected patient, why did the government give you $1 million to do a research project that is basically going to say that conclude the same thing?
Well, it's one of the first. Yeah, no, but it's one of the first trials with people with drug and alcohol, like people who are in treatment for drug and alcohol issues. So the existing 3 or 4 trials are with general population smokers. So we don't actually know how helpful vaporized nicotine will be with this particular population group. And we do need more evidence, and we do want the government developing policies based on evidence.
My best guess to the answer, Paul, is that I think at the time they decided to fund this, which was 12 months ago now, that New South Wales Health, because they're the ones who funded it, it's not federal funding for this study, really clearly thought that there could be a role with treatment-resistant groups in using liquid nicotine where other attempts commonly fail. I think they generally were interested in that as a question. That's the question we posed.
I'm totally on board with it. But I think it's an interesting contrast between our presenters tonight, some of whom are sort of firmly committed to formal clinical trials, and some of whom are not. And I might add that you've described this as a CTN trial. So your formal clinical trialists might actually say, hang on a minute, the CTN is the official notification for the government when you're using a medication not for its stated purpose for a new clinical indication in a clinical trial. And I think what every speaker tonight has said is that nicotine should not be considered as a therapeutic good at all, rather as a consumer product that might be weighed up as an alternative to cigarettes, which are a widely available consumer product. The reason for that is critical, because otherwise you're comparing cigarettes, which kill 18,000 people a year, but might have, and you're asking nicotine to provide high level safety and efficacy when its competing product is the most lethal substance in this country.
Exactly, and that's why it's quite inappropriate that the TGA is regulating it and setting that high standard, which isn't appropriate for a consumer product, which is how it's classified in every other Western country.
So we really haven't got to the bottom of this, because if it's a consumer product, why are they seeing a doctor to get a prescription? They don't prescribe Ajax.
Yeah, because it's on the poisons list, and the government regulations say that it can only be used legally if you have a prescription.
It's the status of nicotine that's the issue here in Australia. As Colin says, it's a poison, and so to include it in our research, we do need to notify TGA and use it.
So just to play devil's advocate again, one of the main risks with this stuff is diversion, either to children or to babies, or to naive, non-heavily dependent nicotine smokers who are your target patient. So how is this environment in which GPs are writing scripts and people are ordering stuff off the internet, how's that going to protect the community from diversion?
Sounds like that one is directed towards me, I think.
Okay.
I think that you can't, of course you can't. And I think the 3-month supply, 3-month import limit is important, but I have no way of telling if the person is completely overstating their use and they're only using a quarter of that and then selling the rest on the black market. But I think it's like that with any aspect of medicine, isn't it, really? I mean, our role is not to be the judge, and they are innocent until proven guilty. And I guess that's where, if we have a good rapport with the person, and if they know that I'm sort of on their side and this is a trusting environment, etc., etc., we can be pretty open about things. Look, I find the sort of patients I I have. They're the real deal. Essentially, they need this. Unless they're incredibly good liars, I'm pretty convinced by what their actual use is. So, yeah, I think I can just base it on that. But no, there is no guarantee otherwise.
No, and look, forgive me for being a bit provocative. There's actually no guarantee against diversion of medications that we prescribe to anyone unless we supervise the dosing. And many PBS listed medications are either not used for the stated purpose or not used by the patient or put in an envelope and sent to their auntie in Minnesota. So it's not a product. It's not a problem unique to nicotine. And you'll forgive me for asking questions, but I think these are the sorts of things that people, criticisms that people who are unsupportive of this product raise. So I just thought we should not simply preach to the converted, but to be prepared to challenge ourselves. I see Colin's turned his picture on. Did you have a comment, Colin?
I have lots of comments, but I thought I'd let you run the show, Paul. If you had any questions that have come up, if you wanted to be answered, I'm available.
Well, we're towards the end of our time. So in fact, I was going to invite our speakers, including Colin, to add anything that they wish to add or to make any closing comments.
Well, Adrian, here, just one thing I was just going to add in the discussion you were having just before. I'm thinking back to when we did the pilot that Billie was talking about in her presentation. One of the easiest studies to recruit patients to. I mean, patients were literally queuing up saying, please, I want to be in that study. And I don't think that was about wanting to divert it to others. It's that they generally wanted to have a way of trying to stop their tobacco smoking. Some sort of mild increase in Centrelink benefits this year during the pandemic, but if we think back then, no increases for very long periods of time. And this is, as we know, this group tends to spend money on tobacco first before housing, food, many other essentials. And so it's literally sending people broke all the time. And I think that was one of the key drivers why of us not struggling to recruit. So we haven't spent so much time talking about the economics tonight. I know it's been mentioned by every presenter, I think, but we had a big discussion. But that's a key thing too. I think that tobacco smoking is sending you broke, and the very effective public health strategy is particularly harmful for very disadvantaged groups who keep prioritising cigarettes.
Yes, I think that's a great look. I'd like to close this evening. I think there's been a lot of interesting comments about on the chat, by the way, from people who are prescribing it, people who would like it to be prescribed. And I think it would be very, very worthwhile following that chat before we go. I mean, I can see arguments for and against, but it's very hard, I think, for me to see why any strategy, when 18,000 people are dying from tobacco-related illness every year, how any strategy could be considered unworthy of having a go, especially something that's, it might have theoretical harms, but it's very hard to see any actual harms from this product. So I'm very glad that this work is being done. I'm very glad that our speakers have come along and given us a really good view, both theory and from Carolyn, a really nuts and bolts practical view about how to do this in practice. And I very much hope that the Harmony study gets done and generates the results that we wanted to. And it's really great that we still have 43 people online, indicating that I think this presentation has attracted the audience and has retained a good audience right through till just about 9 o'clock at night. So I'd like to close the evening to thank all of our presenters and also to thank Daniel and Abby for keeping the trains running on time and keeping everything working. So good night to everyone.